So nothing like promptness. So a very warm welcome to you all here to the Douse tonight, and all of us who are very much used to the greater Wellington weather or Hutt Valley weather. Typically it's spring and a screaming great southerly has come along just to remind us there's always a bit of a sting in the tail of winter, but not to worry. Welcome to this evening, a Care Alliance event. My name is Paul Elsford, I'm the MC for tonight, so I'll take you through a couple of things and then pass you over to our key speaker. But obviously tonight is very much wrapped around the End of Life Choice Act that we are well aware of. And this is a chance for us tonight just to maybe unpack that act a little bit more, have an opportunity to hear our guest speaker, John Kleinsman, and also later after he's finished, an opportunity for an open Q&A session with a panel which I'll introduce a little bit later on as well. Just before we begin, I'm just checking that everyone's done their COVID duties, all signed in and all that sort of stuff. That's very good, thank you for that. And also, I think if I'm correct, judging by the green lit human figures, that's where we probably head if something goes askew, so hopefully it won't. But also the stairs directly behind us and up is where I found the loo, so hopefully that's where the toilets are. The other thing you might have noticed as well, which is very important to mention, is behind us is food, so there is going to be supper afterwards, so if you do need a bit of sustenance before we head back out into the call of the evening, that opportunity will be there as well. So as I mentioned, there's a chance for us to listen to John first, and then we'll have a bit of a Q&A after that. And we'll probably look to finish formally around 8:15-ish, and we'll see how things go from there. All right. Before we do the Q&A session, I'll also introduce a couple other people who will be part of that panel as well. So firstly, now what I'd like to do is introduce you to Dr. John Kleinsman. John's going to be talking tonight for about the next little while. He is the chair of the Care Alliance, and he'll talk a little bit about who they are in part of his talk. And John's been involved in researching, writing on and speaking about the topic of assisted death since 2012, when Marion Street's bill was first put on the private member's ballot. He's also director of the Nathaniel Centre for Bioethics, which is based in Wellington City. He's a long-standing member of various health research ethic committees since 2001. And before his entry into the field of bioethics, John worked for 10 years as an advocate for people with intellectual disabilities and their families, and he's also worked in drug and alcohol addiction field as well. He also supports Arsenal Football Club, but we won't hold that against him. So without any further ado, unless I've forgotten anything horrifying now? Good. Without any further ado, I'd like to introduce you to Dr. John Kleinsman.
Thank you, Paul. I wasn't going to use the mic. This one's not working. Can people hear me okay without it? Okay, yell out if you can't, because I want to hold the remote in the other hand and I need to turn my pages as well, so I'll turn this off. What's that?
I think you should use it.
Okay. I don't know whether we can.
No, you've got a good loud voice, you'll be fine.
Look, if it's a problem after a few minutes, I'll just someone put your hand up and we'll work something out. I'll use the handheld if necessary. Thank you, Paul, for the invitation, and thank you to each of you for coming out tonight. As Paul said, I'm the chair of the Care Alliance, and our mission, as stated on our website, is to nurture more informed conversations about dying, promoting equal access to excellent palliative care, suicide prevention services and support for disabled persons, conducting research into attitudes and experiences of dying in New Zealand and overseas, and opposing the legalisation of euthanasia and assisted dying. The Care Alliance has a family of organisations, and there's a list of them there, and we cover a number of fields: medical, disability, social policy, ethics, and also faith. So our position on the legalisation of assisted suicide and euthanasia is well known. We're opposed on largely ethical and social grounds, and we remain opposed in principle for a number of reasons that are shared by all of the organisations that are part of the Care Alliance family. Separately and independently, some of the organisations also oppose euthanasia and assisted suicide, assisted dying, for reasons that may be unique to them, and for some of the organisations it includes religious reasons. But the Care Alliance never has and never will argue the question of intentionally ending the lives of patients from a faith perspective, for the simple reason that we wouldn't be able to agree on what that was. However, I'm not here to convince you about why the Care Alliance is ethically opposed in principle. That's not the conversation that needs to happen at this point in time in New Zealand. Likewise, Paul mentioned I'm the director of the Nathaniel Centre, which is a Catholic bioethics centre, and I'm not here to represent the centre or the church or my views, my religious views on this. Rather, we all face a big challenge, and that is to put aside, I think, our ideological views about euthanasia and assisted suicide, whether you are in principle opposed or whether you are in principle supportive of the idea of assisted dying. The point of tonight's discussion is to focus on what the referendum question is all about, because the referendum is no longer about the idea or the concept of assisted death, or whether a case can be made for it. Yes, a case can be made for it. We all know that, and I will cover that case very briefly in my presentation later. But the referendum question is all about the law that has been passed. It's an act that cannot now be changed, a law that will be enacted in its current form if more than 50% of voters vote for it on the day, or will not be enacted if more than 50% of those who vote vote no. So whether you are in favour of assisted dying or opposed, we must all ensure that the act that is being passed is fit for purpose. Is it good enough? Is it a safe enough act? And these, I think, are the most important questions for all of us. Those of you who are here, some of you who are here may well be opposed for ethical or religious reasons, and you'll likely remain opposed. Although having said that, I know many people in that position, religious people included, whose starting position in this debate is to actually vote yes to legalising assisted death, because they don't want to force their morality, their views, their religious perspective, if you like, onto other people. And to people in that group, and to those of you who in principle believe that some sort of assisted dying is a right, is a good, I ask you to think seriously about whether you are prepared to bring in a law at any cost. I personally think that whatever side of the line we are on with respect to our fundamental position about the desirability of assisted dying, we should all be able to agree that we don't want a law at any cost. If we are to have a law, it should be the best law that we can have, the safest law that we can possibly have, or at least a law that is acceptably safe. It's all about the law. Or as one lawyer recently put it, the referendum concerns a set of rules that have already been drafted and enacted by Parliament. Those rules will come into force automatically if a majority vote in favour of them. Before endorsing any set of legal rules, we should all be convinced that the proposal is watertight, especially in matters involving life and death. Now, I've not come here tonight to tell you how to vote in the referendum. You will each of you make up your own mind. But, and it's an important but, your decision should be an informed one, which is why what I propose to do tonight is to focus on the key aspects of the Act, an Act which research has shown most New Zealanders don't actually understand. As one MP put it in the lead up to the final and third vote in Parliament, the first question is not whether some people should die in a way that the bill allows, but whether people could die in a way that the bill does not allow. Put another way, the question is not whether it is possible to imagine whether a person who is competent, in good mental health, has a supportive family and whose first language is English might be able to make a choice and not be bullied into an early grave? But what is the number of vulnerable New Zealanders who may be coerced to exercise the so-called choice, absent other choices? A further question might be not whether the bill is better than what it was before, less dangerous in other words, but whether it is good enough now. So the question before us, the referendum question, is, I suggest, a very practical one, a very pragmatic one, with a legal focus. We're all being asked to think like lawyers. First, just a quick question about definitions. Again, research shows that many New Zealanders don't actually understand the actual terms involved. The End of Life Choice Act 2019 uses the term assisted dying. It's a generic term which actually encompasses both assisted suicide and euthanasia. And unlike some jurisdictions overseas, the End of Life Choice Act will, if it is passed, legalise both assisted suicide and euthanasia. Assisted suicide occurs when lethal drugs are supplied to a person at their request and are self-administered by the patient at the time they choose to die. Euthanasia, on the other hand, occurs when a third party is involved and when the third party actually administers that lethal drug. So now to the Act itself. How much do you know about the processes and safeguards in the End of Life Choice Act? I'm now going to give you 12 questions to test your knowledge. And once we've gone through the 12 questions, then I'm going to go back and we'll look at the answers and I'll unpack those answers a little bit more. Monica, who has helped set us up tonight, has helpfully organised pads and pens. So as you go through the questions one at a time, I suggest that you note your answer down and then we can come back and compare your answer with what I'm going to suggest is the right answer for each of the questions. 10 of the questions come from the Vote Safe website and I've added 2 of my own at the end. So, the first question. I'll go through these fairly quickly. Will the Act automatically become law if a majority vote in favour at the referendum? If you were listening, I've already told you the answer to that, so I expect that everyone here is going to at least get one question right out of it as well. Question 2. Can a terminally ill person be eligible for assisted dying if they have depression or a mental illness? Yes or no? Question 3. Do the doctors who sign off on the assisted dying need to have met the person before? Yes or no? Question 4. What's the shortest time the assisted dying process could take? You've got 3 options there: 4 days, 10 days, or 20 days. Question 5. Does a doctor have to talk to the person's family before providing assisted dying? Yes or no? Question 6. Do independent witnesses need to make sure that the person's choice is free from any pressure? Yes or no? Question 7. Will this Act make it legal to turn off life support? Yes or no? Question 8. Does an eligible person need to be in physical pain to request assisted dying? Yes or no? Question 9. Do people have to try any treatment options first before requesting assisted dying? Yes or no? Question 10. Can an eligible 18-year-old receive a lethal dose without their parents knowing? yes or no? Question 11. Approximately how many people annually would fall within the scope of the End of Life Choice Act? We've got 4 possible answers there. So how many people would in principle be eligible to ask for assisted dying on an annual basis in New Zealand if the law comes to pass? Roughly how many?
So how many people are going to die of a terminal illness?
That meet the criteria.
Yeah, would basically meet the criteria for this.
Okay.
In question 12, which is the last of my questions, does a person need to be competent at the time of administration of the lethal dose? Yes or no? Can people hear me okay at the back without the microphone? Okay, okay. Now, before coming back to the answers, I want to have a look at the case that can be made in favour of an assisted dying law. The past weekend featured a media piece in which former Labour government Minister of Finance and Deputy Prime Minister Sir Michael Cullen declared his support for the End of Life Choice Act. Some of you may have seen that either on stuff online or in the Don Post on the weekend. I think Sir Michael is an articulate spokesperson for the case in favour of legalisation. It's also very personal for him because, as he explained in the piece, he has been diagnosed with stage 4 small cell lung cancer and secondary cancer in the liver. Firstly, in this piece, Michael Cullen makes it clear that the issue for him is not about pain or fear of pain. He acknowledges that there is excellent palliative care available in New Zealand, but that he is mostly concerned about dignity and control in his final days. He elaborates further on what he means by losing his dignity later in the piece when he states that, quote, "I do not want to lose control of my bodily functions so that my dignity has disappeared with the ebbing of my life. When I reach those last stages, if that is the prospect, I want the choice to be able to decide when the time is right to complete the circle of my life." End of quote. This is quite a commonly expressed sentiment, and I've certainly come across it numerous times. Although I know that many of my friends with disabilities, some of whom require that sort of care for their bodily functions day in and day out, including toileting and showering, would have something quite strong to say to Sir Michael about that. And they would be adamant that they still live dignified lives. But it is quite a common attitude amongst New Zealanders. And for people like Sir Michael, it is about control and choice rather than pain. To quote again from the article, "Many of us with terminal illnesses think about what the last weeks or months may be like. Our health services talk us through this. Our good people in the hospice movement provide excellent end-of-life care for many. We are told our pain can be controlled to a tolerable level. This will suit many of us. But for many others, myself included, there is an overriding issue of control. It offers to people like me the chance of finishing the life I have enjoyed so much in a way that is consistent with my moral beliefs and my sense of the dignity of human life." End of quote. As a lawyer friend of mine puts it, as New Zealanders, we like the idea of having a choice. We also like the idea of showing compassion towards those who are suffering. So, dignity, control, choice or autonomy, compassion, and the avoidance of a bad death. These values, articulated by Sir Michael and others, are important values to uphold and to promote. And I would say they're actually values that most New Zealanders would want to uphold and promote, whatever side of this particular issue they might find themselves on. So why would any of us want to deny Sir Michael or others this sort of choice. We would only be justified in doing that if there would be very good reasons in a society like ours, which privileges, quite rightly I think, individual choice. Those reasons, I think, would have to relate to unintentional dangers that the law would pose for other people. And that's why, and there's numerous examples we could bring up tonight, it's why as a society we do limit people's choices and freedom in areas such as drinking and driving, or wearing seatbelts, to name a couple of fairly mundane examples. But also more recently, I think, we've seen this play out in the way in which as a country we have put huge restrictions on people's behaviour to keep people safe, the most vulnerable people safe, from the COVID-19 virus. At this point, let me say that Sir Michael Cullen is not one of the people I worry about in terms of being vulnerable when it comes to this law. He already has choices, lots of choices. He's articulate, he's well connected. He clearly has a good understanding of the issue and what's involved. Do I have a real fear he'll be coerced? No, I don't. And there are other New Zealanders who would be in the same position as he is, able to talk about accessing the best of palliative care until they want to take that control over the last few days. For Sir Michael and others like him, legalising assisted dying will provide him with another choice to add on to the other many choices for health care and care that he already has. Neither am I particularly concerned about myself being coerced into an assisted death. I'm also, I think, reasonably articulate, and in a position where my saying no comes out of a place of knowing about the law, having a family who will care for me whatever comes, and also coming from a place of knowing that I have the choice to access good quality palliative care, that I don't have to endure pain at the end of life. Both Sir Michael and people like him, and myself and other people like me, and undoubtedly many of you in this audience tonight, are amongst those people referred to in the earlier slide, capable of dying in a way that the bill allows, more than capable of making a choice that is not the result of being bullied or being coerced. So we don't have to deny that this law won't work for some. But will it work for all? No, it won't. Which brings me to reflect on the fact that for all of us, the first question, I think, ultimately, when it comes to this referendum, has to be not about ourselves, but how me having this choice, being able to make this choice, would impact on others who don't have the same choices that I might have. Those who don't have the same caring families that I have. Those who don't have the same choices for health care that I have. Those for whom the choice would potentially be a Hobson's choice or a desperate choice. Which again brings me back to the real point of this debate, the substance of the law, and whether, at the end of the day, the law that we are considering is good enough, is safe enough. Because if we were to have some sort of law in New Zealand allowing assisted dying, it could be quite different from the End of Life Choice Act that has passed through Parliament. It could be much more like the Victorian law, for example, which is quite narrower than the End of Life Choice Act in its scope, and also contains many more safeguards than the End of Life Choice Act. Let's quickly look at the eligibility criteria. And these are available on numerous websites, including the Vote Safe website, Risky Law website, Yes to Compassion website, Care Alliance website. You can also go and look up the bill itself. So the eligibility criteria are there in the law, and you should be familiar with them. So, who will be eligible? What are the criteria? New Zealand citizens or permanent residents. So you must be a New Zealand citizen or permanent resident. You have to be 18 years and older. And there's already a question mark about that because the Attorney General challenged that in terms of the Bill of Rights Act that we have. So I suspect that if the law passes, that'll be challenged pretty quickly. Suffering a terminal illness, and that's not defined in the Act, and Sinead may say something about that later on. Suffering a terminal illness that is likely to end the person's life within 6 months. There's a bit of guesswork in there, and again, that's something that the physicians and doctors have spoken quite a bit about. You have to be in an advanced state of an irreversible decline in physical capability and experience unbearable suffering that cannot be relieved in a manner that you, the person themselves, considers acceptable. And lastly, you have to be competent to make an informed decision about assisted dying. So those are the eligibility criteria that are actually set out in the law itself. So let's go back to the quiz and to the questions that I put. The first question: will the Act automatically become law if a majority vote in favour at the referendum? The answer to that is yes. This is a binding referendum. The cannabis referendum question, which we're also being asked to vote on, is not a binding referendum, because if a majority of people say yes to that, the law, or the proposed law, and the government has put one up, would still have to go through the normal parliamentary process and will be subject to the MPs passing it or not passing it. So that's the difference between the End of Life Choice Act referendum question and the cannabis referendum question. So the referendum is binding, and there is no provision for any changes to be made to the Act. It is what it is. It will be passed in the form in which it is, as it is now written. And if you were part of a group of people who came to the conclusion that the End of Life Choice Act could be better, that it could be safer, then you need to know that if you were going to vote yes for it, those shortcomings will become part of the law. Interestingly, recent polling shows that at least 2/3 of New Zealanders are unaware of the fact that there was even a referendum on euthanasia in the upcoming election. So there's a lot of work to be done to actually educate people about this. Question 2. Can a terminally ill person be eligible for assisted dying if they have depression or a mental illness? Now the law actually states in section 5, subsection 2, a person is not a person. I always admire lawyers who can read this because it's quite convoluted. This is what the law actually says. It's a quote from the law itself. A person is not a person who is eligible for assisted dying or an eligible person by reason only that the person is suffering from any form of mental disorder or mental illness or disability or is of advanced age. So the correct answer to this question is yes. A terminally ill person, as the Act is written, can be eligible if they also suffer from depression or mental illness. Although as the Act is written, they cannot access assisted dying for reason alone of having a mental illness or being disabled or being of advanced age. Keep in mind that competency and depression or having a mental illness are not mutually exclusive. Under this Act, the person with a mental illness could still be competent, could be deemed competent, and therefore could be eligible. Keep in mind also that this Act does not require any assessment for depression unless the question of competence arises and is obvious to the doctor. And we know that even mild depression can skew people's judgments about the worthwhileness of their life. There's plenty of research done on that. And the New Zealand Medical Journal, there is some recent research which shows that more than 40% of terminal patients are thought to fit the diagnosis of a depressive disorder, and yet depression remains largely unrecognised. I think this Act should include screening for depressive orders, but it doesn't. Question 3. Do the doctors who sign off on the assisted dying need to have met the person before? Yes or no? The correct answer to this is no. Both doctors could be meeting the person for the first time. In fact, the first doctor does not actually need to talk to the person face to face when deciding if they are eligible and checking for coercion. This means that the doctors can sign off on someone's assisted death while knowing very little about them and their situation. How can this happen? It can happen for several reasons. Increasingly, as I'm sure some of you will be aware, if you turn up to your medical practice, they have doctors rostered on and you don't necessarily get to see your family doctor anymore. I know that when I go, I get a different doctor pretty much every time. More pertinent to the Act, your doctor might actually be somebody who has decided not to participate in assisted dying, and that is part of the law. He or she can opt out using their freedom of conscience, in which case you will need to go to another doctor to be part of that process or to get that process going. And again, that could be a doctor that you do not know. So, further, while the Act states that a doctor must confer with other health practitioners who are in regular contact with the person for the purposes of ensuring that the person isn't being pressured or coerced, and that's a critical question, I think, and that's section 11. The New Zealand Medical Association had pointed out in a recent flyer that they've put out about the referendum that doctors are actually not permitted in law to inquire about a person's competence from other practitioners unless the patient gives that permission to them. That's how our medical laws work. So again, it looks good on paper, but the person actually has to agree for a doctor to go and talk to other doctors. By definition, it's also most likely that the second independent doctor who's part of this process will not know the person either. And it's significant, and many people aren't aware of this, that the doctor who's providing the second opinion has no obligation to determine or check out for coercion or pressure. That comes down to the first doctor only. Finally, even when a doctor knows the patient, the NZMA points out that coercion, subtle coercion, can be almost impossible to detect. And the NZMA notes, in addition, quote, "The Act does not specifically address other types of pressures, such as barriers to access services or care, social or financial pressures, loneliness," and that is a reason 17% of people in Canada recently cited loneliness as the key reason why they were actually asking for assisted dying. That's in their latest report. Neglect by family members or carers, and feelings of self-perceived burden, which are reported as being a significant problem in anywhere between 20 and 65% of terminally ill patients. Of the people who died in Oregon's Act in 2019, 59% cited concern about being a burden. So there is no process in this Act to actually help doctors to determine these different levels of coercion or pressure. Question 4. What's the shortest time the assisted dying process could take? The correct answer is actually 4 days. According to the Ministry of Health's report to Parliament, the process could happen as quickly as 4 working days from request to death for those in hospital settings. So it is qualified. They do say that if you're in the community, they think it would take longer. But, and this is important, the Act itself only stipulates that the doctor needs to prescribe the lethal drugs at least 48 hours before administration. There is no other reference to time frames. So both the 4 days and the longer period if you're in the community basically come down to the amount of time it takes to process the request. The Act itself puts no limit on that other than the 48 hours. Compare this with countries, with the state of Oregon, where there is a 15-day cooling off period. Victoria, Australia, there is a 9-day cooling off period. Canada, 10 days. Hawaii, 20 days. Why? Because people change their mind. So there is no stand-down period in our Act, no time frame involved other than the 48 hours. The Act actually allows people to request a lethal dose as soon as they receive a terminal diagnosis. And there's a real risk that some would choose to end their life while still in shock, grief, and under the stress of recently having received a diagnosis. Question 5. Does a doctor have to talk to the person's family before providing assisted dying? The answer to this is no. The doctor doesn't have to talk to the person's family before signing off on a person's assisted death. The doctor needs to ask to speak to the person's family, but the person can refuse that permission. What the Act states is that the attending doctor must encourage the person to discuss their wish, but at the same time, in the following clause in the law, it also stipulates that the doctors must ensure that the person know they're not obliged to actually talk to anybody else. As already noted, a doctor must confer with other health practitioners, but again, that can only happen if the patient gives permission for that. The legal requirements for accessing an assisted death under this law, which concerns weightier decisions, are fewer and weaker than what is demanded in contract law in New Zealand. New Zealand contracts law requires an examination of witnesses, arguments by lawyers on both sides, as well as consideration of legal precedent. So contract law in New Zealand, which deals with less weightier issues, has stronger requirements around the need to actually check out and have witnesses and lawyers on both sides. Question 6. Do independent... Where have we got to? Oh, sorry, I'm going the wrong way. Do independent witnesses need to make sure that the person's choice is free from any pressure? Yes or no? The answer is no. Overseas laws specify that the intending doctors or nurse practitioners are not eligible as independent witnesses. In Oregon, there are 2 witnesses required. One of them has to be totally independent. In Canada and Victoria, the laws there require 2 independent witnesses as well as the coordinating health practitioners who are involved. What's the point of having independent witnesses? It obviously relates to the question of potential abuse and as a protection against coercion. And I'm really at a loss to explain why our law in New Zealand doesn't include those clauses like the laws overseas that I've just referred to. Will this Act make it legal to turn off life support? Question 7. The answer to that is no. And the answer to that is also a fairly easy one, although many people are confused about this, but basically it's already legal to turn off life support. The Act is not about turning off life support, it's about intentionally ending the life of somebody with a lethal dose. So life support, it's already legal. It's already legal to refuse treatment in New Zealand. It's already legal to have a do not resuscitate order in New Zealand. It's already legal to administer as much medication or drugs as required to relieve pain, even if it is deemed that it might shorten a person's life. The Act is not about that. Any of those things, all of those things are already legal and available. In 2019, a nationwide courier market research poll, so that's only 6-7 months ago, found that 74% of New Zealanders thought the Act would make it legal to have machines turned off, and 70% thought the Act would make it legal for people to choose not to be resuscitated. Question 8. Does an eligible person need to be in any physical pain to request assisted dying? The answer to this is also no. A person doesn't need to have physical pain to be eligible for assisted dying. The Act requires that a person, quote, experiences unbearable suffering that cannot be relieved in a manner that the person considers tolerable. But it doesn't state that it needs to be caused by physical pain. Nor does it state unbearable suffering that can't be eased, which, interestingly enough, is the phrase that the government referendum website actually uses. That is actually incorrect, and a number of us have challenged the Electoral Commission about the wording on the government's official referendum website. So most people assume that the Act would only be available to a few people with severe pain at the end of life, but that is not actually the case. You don't have to be in pain. I see I started to write something about Oregon there. I don't know what I was thinking, but I obviously never finished it. I might have got those slides mixed up. Question 9. Do people have to try any treatment options before requesting assisted dying? Again, the answer to this is no. A person does not need to have tried any treatment before requesting assisted dying, even if those options would likely help to cure their illness or treat their symptoms. Under the Act, assisted dying does not have to be an act of last resort. The NZMA in their document says that the Act lacks clarity around whether the threshold criterion of needing to have a condition that will likely end your life within 6 months is met by people who decline effective treatments or cannot afford or access such treatments. That's quite an important phrase and quite an important question. So people like my wife, for example, who are type 1 diabetics, could in theory choose not to take their medication and could then in theory become eligible. It hasn't been tested, but we do know that in Oregon, people who stop treatment for conditions that they could otherwise live on with do become eligible for the Act. So at best, the End of Life Choice Act is unclear about that. I would argue, I'm not a lawyer, but I would argue that if the Act doesn't rule it out, then in fact there's no reason why people couldn't actually be eligible if they made a decision like that. Question 10. Can an eligible 18-year-old receive a lethal dose without their parents knowing? The answer to that is also yes. And it follows on from the earlier question that I had here. This has been somewhat contentious, and David Seymour got upset about this question being asked and made the point that it's somewhat, just grandstanding, that it's hardly likely to happen. He may be right, but the point is the Act doesn't actually rule it out. It is possible under the End of Life Choice Act for an 18-year-old
Why
to take
18?
this.
Because they want to bring down the voting age. Will that then come down as well with it?
Yep.
Because, I mean, an idiot of 16-year-old driving a car, they should be 18, but they're allowed to be 16. Now they're allowed to vote.
So the Attorney General raised that point in his assessment of the Act. So,
That'll go down with that.
yeah, good question.
16-year-old.
So the last question, second to last, question 11, I think. Approximately how many people annually would fall within the scope of this Act? And the answer is 25,000. That is the number of people who are eligible on an annual basis for palliative care in any 1 year, estimated as a percentage of the total number of deaths in New Zealand every year, which is approximately 33 or 34,000. So again, the point is, this Act is not designed for a very small number of exceptional hard cases, which again is what I think some people think. Final question. Does a person need to be competent at the time of administration of the lethal dose? And the answer to that is also no. Unlike overseas laws in Victoria and Canada, where a person must be reassessed, they must be assessed for a second time for competence at the time of administration, at the time when the person makes a decision to have the drug, whether they are self-administering it or whether they are having it administered to them by a third party as a doctor. Lawyers have also pointed out that the competency clause in the Act only calls for a specialist psychiatric assessment when questions of competence are thrown up. And the criteria for competence in the Life Choice Act is based on a presumption of competence. That's how our law in New Zealand works. That's how health law works. The doctors don't actually have to test for it. They only have to query it if in fact it's obvious to them that the person is incompetent. So in fact there is no test for competence. It's up to the doctor to say, it looks to me like you're incompetent, and that's when the other steps in the Act come in. So in practice, this means that the role of the specialist psychiatrist is to ensure that people are actually not wrongly excluded from the Act, from requesting an assisted death. But the specialist, there is no place in the Act for a specialist to ensure that persons might be wrongfully included. So for many people who might not be competent, there would be no assessment and no way of knowing that. So, final comment from me, and then I've got a small clip that we'll watch and listen to. If the End of Life Choice Act was an assignment that was submitted in response to a question, design a safe, assisted dying law, then if I were the marker of that assignment, if I was the lecturer for that course, I'd be asking for a resubmit. That's my own personal view on this. It's for each of you to come up with your own decision about that. As Dr. Rod McLeod, Professor Rod McLeod says, this is about a deeply flawed Act and it is extremely dangerous. That's the quote from someone who should actually know and who's very experienced in palliative care. So onto this clip, which is of a palliative physician called.
I've had patients with severe pain who have asked persistently for euthanasia, and we've said, we can't do that, but work on your pain. And to have them weeks later say, I'm so glad that euthanasia wasn't an option, because when I was in so much pain, I was so desperate for it, and now you've got it under control, and I'm so glad to have this time. I'm really loving this life and this time at home. And that's a great thing. I'm a palliative care physician, so I look after the dying, anyone with a terminal illness, helping them with whatever troubles them, including pain and symptoms. In this law, it says that people are eligible if they have unbearable suffering. We imagine that that's terrible pain, but it needn't be. It may be that they find themselves in what they think is undignified circumstances where they can't toilet themselves, where they have no pain or no physical suffering. I had a man who had cancer in his arm, and his arm had been amputated. So he had one arm and walking around on his legs, and then got cancer spread to his spine and paralysed his legs. So he had just one functional limb, and I went to see him and I said, oh, that's really tough. And he looked me in the eye and he said, this is nothing compared with the suffering when I had depression. And that hit me, how mental illness and particularly depression can be a major component in people's suffering. And if we're missing that, we're not treating that or taking that as being a normal part of dying, then these people are missing out on life and good quality. Most of the doctors working in palliative care are opposed to this. We have always been people who have helped, and killing people is different to what we signed up for. Many of us said an oath, whether it was a Hippocratic oath or a similar oath, to care for people, and it just changes how we see the role of a doctor as both a healer but also now a life taker. This will change patients' trust of doctors. I've had a patient already a little while back who their doctor spoke a lot to them about euthanasia and said, oh, it's a pity it's not yet legal, and then started increasing their dose of pain relief, which they thought was unnecessary. So they got very scared and left hospital as quickly as they could because they were concerned that their doctor was trying to hasten their death. And whether that person was doing that or not, I don't know, but it certainly scared the patient and would make them not want to return to hospital. Treatment for suffering is already legal in this country. Doctors can use pain relief, can use other medications to ease suffering, and if all the standard treatments fail and there is nothing else that will relieve the suffering, palliative sedation can be used to ease the suffering of a patient without a limit. And I want people to know that they matter even when they can't function as they used to. People are important, whatever they can do.
Okay, that's me. Back to you, Paul.
Thank you, John. Okay, so we'll plough on. What I'd like to do firstly is ask Sinead and Peter to come on up and join John. So what we're going to do now is a bit of a Q&A. I've suddenly realised during John's presentation that we have one working microphone. So we're going to make this a roving mic, and I guess for Sinead, Peter and John, you're just going to have to bellow out your responses. So the roving mic is how we'll go about it. We've all done Q&As, so look, basically just the usual simple rules about one person speaking at a time. If you have a question, that's absolutely perfect. When you get the microphone, that means the floor is yours. But if you have a short statement, that's equally fine as well, but the operative word being short. And we'll go around this, around the Q&A for about 30 minutes. So what I'm going to do firstly, just as you gear yourself up for those questions, I'm just going to introduce Sinead and Peter. Now Peter, what I'm going to do is I'm going to give you 10 seconds to introduce yourself, because you'll do a far better job than me. So I'll throw you the microphone very shortly. And for Sinead, for those of you who don't know her, she's an associate professor of palliative medicine at Otago University, and has a background of looking after patients who are dying in at least 4 different countries. And she has been a significant person who has discussed the impact of this particular act. So Sinead, a very warm welcome to you. Peter, you've got 10 seconds, honestly. I'm so generous.
I'm involved in a group called Vote No to the End of Life Act. You can guess what we stand for in relation to this particular act. I've been involved in the issue for a while and have some genuine concerns along the lines that John has outlined, so happy to participate.
Appreciate it, thank you. All righty, just raise a hand and we'll begin the process. Will you help out through it?
Thank you. Can you hear up here? No. Can't hear. Right, I'll just speak up. So this question's for Sinead, probably. So it's just about the conscientious objection provision for doctors in the Act. And I just wonder if it really is, a true conscientious objection provision, because if the doctor doesn't want to participate, they have to refer them to someone else who will, that's how I read it anyway, assist the person. So is that, in a way, that doctor might feel that they're actually having to cooperate. Is that how you would see it?
Yeah, that's how I would see it, yes. Because it says to refer on to tell the patient about the SCENS group, which is the registry and the group that will have doctors on it who are in favour of euthanasia, support it. So if I were a doctor and the patient asked me for that and I couldn't participate, I couldn't in conscience either refer them. So I would find that extremely difficult. But it's kind of bigger than that, because I actually care about people. So if someone I'm looking after then asks for euthanasia, the way I care is that in my clinical judgment, I do what I think is best for that person. And for all the years that I'm working in palliative medicine, I've never thought, oh, I wish we had euthanasia because that's actually what we need now to care for this person and look after them. I've never said that. I've never thought that. I know that, and most of the palliative care doctors and nurses in New Zealand would believe that. So the idea of actually a patient not being able to look after them and care for them and explore their suffering, as we have done for years and do well in palliative care, is extremely sad for us that we won't be able to practice the care that we can provide to people. So it's bigger than just the legality of conscientious objection. It's actually that we care about the person and we don't think they need to do this to relieve their suffering.
Is that microphone working?
Didn't seem to.
Is there a little wee green light on down the bottom?
Thank you.
I'm not sure
Who
my question.
is for?
My question's about scope of the Act. So most people think that this Act refers to elderly people at the end of their life, but there was a question in the quiz about an 18-year-old being able to get it without talking to their parents. So I was just wondering if you have any data on how many young people, 18-year-olds, would be within scope
I can give you a rough idea on that. I think the question is how many younger people might come within the scope of the Act?
Do you want to stand up there?
Yes, sir. In New Zealand, about 200 people a year between the ages of 14 and 24 would come within scope. Now, I can't break it down further than that. Clearly, the 14 to 70-year-olds wouldn't qualify at the moment. But let's say we conservatively took about a third. It seems like probably 1 to 1.5 a week would come in the scope of this Act. In terms of in principle qualifying.
I was just wondering, because like my mother had MS, and when she was dying, she wanted this Act to be around. And it wouldn't have changed anything. Well, it was 20 years ago, it wouldn't have changed anything. But she always said she wanted to go on her terms. This disease took that away from her, and she laid like in a coma for a week afterwards. She wanted to go merrily, get drunk, have the injection, and be done with it. But nothing left her that dignity. Not whether she had a catheter, she had to go on a commode for the toilet, all that was all. She'd done that for many years. Even when I was a kid, I used to lift her onto the toilet. But this one wee thing she wanted, if the Act could be done better, that could help those people. She was only 60, but she didn't have the choice. And I think that is wrong. That's why I wanted to vote yes for the Act. But after seeing this, it's quite strange.
I mean, it's very hard for us, particularly as a doctor. Well, I'm not sure that I have anything particularly valuable to say, because it's very hard for me to speak about your mother or
it's a terminal illness.
Yeah, your experience. The only thing is that the legislation, law doesn't just, it's not just for one person.
No,
you have to think.
That's right. That's what I said. If it could be good.
Exactly. It's just as you've said. You have to think of like 360 degrees around this. How would this impact 4.5 million, whatever the population of New Zealand? And in a way, that's how the doctors who are the majority opposed to this legislation, we think not just about the person who's in front of us, but we also have an advocacy role. So we think about all the other people involved and the potential harm and the burden that this could give to people. So I can't answer directly about your poor mother, but we have to think on a wider scope, on a wider basis about the impact of this on everybody.
Because it can be abused.
That's right. And unfortunately, the people who I work in general medicine as well as palliative medicine, so at the emergency department and people coming in, and there are a lot of older people who come in and say to me, don't do much for me. I'm a burden. So if they're saying that now, when this legislation isn't there, I'm just very concerned about them, how they already feel a burden on us, I think, on society. How will they interpret this legislation? Yeah, because it will release you, my family. Out of love, they might even do it. And that's what's heartbreaking. That's, for me.
Thank you. I think just behind here. I think the microphone's working.
Thanks. My name's Jen. I'm a supporter of the bill. I really enjoyed the first part of your presentation, John. It was very balanced and very powerful. The questions, some of them I think are quite spurious in that, on that side. I do have, I'll just stick to one point though, but what about treatment? My understanding is from the Act that one of the things the GP has to do at the time of being asked about voluntary euthanasia is they need to give advice on other treatment options. And the quiz also leaves out the fact that the Health and Disability Act protects me as a patient, or allows me the right to refuse treatment. It allows me the expectation to be given all my treatment options, so that's already in the Act, and that in the Health and Disability Act, and that is in this Act. But the Health and Disability Act goes further and allows me to refuse treatment. So the example you gave about diabetes, for example, any diabetic, any time can say, and I know people who have diabetes and they don't follow their treatment plan. They get very sick and they die. So I guess my question is, I don't understand the question in the context that you put it. Because it seemed to me that you're making it alarming that people don't have to accept treatment when that is already in our law.
Oh yeah, that's true. The point is now, if the person who's diabetic chooses not to take their insulin, they will die, but they're not. There is no provision for them to be euthanised or to have assisted suicide. So you're right, that is possible now. There is already, and I did mention in one of my slides that it is already legal to refuse treatment of any sort. That is absolutely right. I'm not arguing with that. I suppose the point I was trying to make was, and this concerns me, and it concerns a lot of people that I've talked to, the perception that many people in New Zealand have is that we need this act for a very small group of really hard cases. And if you had followed the debate through Parliament, the MPs brought up some pretty horrific stories. And you know, there are people who have terrible diseases, terrible illnesses. There are options for them. But this law is not designed for those very few hard cases. Could we design a law that was much narrower, that was much more specific, that actually took account of those really hard cases? I think we could. It would look a lot different from this law. I think we could do a lot better. And that was part of the point of what I was trying to make. But as it stands, and I would stand by everything I said tonight, I hear what you're saying, you thought something was spurious, but as it stands, you know, the law actually does not require people to have treatment or to have an effective treatment or even try palliative care. So it's my way of making the point that this is not for people who are in those desperate, just for people in those desperate hard situations. It would in fact encompass a much bigger group, potentially up to 25,000 people a year.
Oh, okay, hang on, I'm just going to... Yes, sir, you? Yep.
I'm not too sure. Can you hear that?
Yes.
Right, I'm not too sure of the question here. It's in 4 parts, and it's based upon a week ago on Checkpoint Radio. There's a case in Hastings of a man with a brain tumour who, according to his wife, the pain control could not be done. She went out, came back, and found committed suicide. And she was advocating this bill. So in light of that, I'm wondering about the issue of palliative care. In my position, I understand the current law does not give you a statutory right to palliative care. Does this act do that? It's either yes or no. I've waded my way through it, got drowned, gave up. If it does, the second question about palliative care relates to has it prescribed in law what the procedure is to be in the process of measuring the quality of what is occurring? It seems to mean different things to different people. And if a person like me, who knows nothing about medicine, has a power of attorney for carer and thinks something's not right, what rights have we got under the law to enforce palliative care to a standard which is the person that we think they should have?
No.
Over here.
Sorry, I apologise, I don't quite understand the question, but I heard the word palliative care. So,
Well, if you want it straight, the accusation made in the Hastings case of a week ago that there is a point of time when palliative care is a failure. And the man, the pain was not contained and he committed suicide. And his wife contends we need this act so that he cannot have to be put through that process. Now the argument on the other side of the fence is yes, that palliative care is all marvellous and wonderful. You can control the pain. Well, there has to be a method of measurement of that prescribed in law of standard of performance and quality measurement. Is it in the Act? Do you have a right to palliative care, yes or no?
no, it's not
And
in
if
the
you've got a
Act.
power of attorney, how does a layperson know what's going on?
Yes, all I know is there's no right to palliative care in the Act. So, and I mean, I wish we were having a referendum on something like that, because I think that's, from my point of view, a much more productive way for the society to think about how we care for people who are dying. So I understand there's some nurses who work in palliative care in the audience, there may even be some doctors. So palliative care could be improved in New Zealand. There isn't equitable access throughout the country for the same high standard of palliative care. So there's definitely improvements that can be made. But I think this palliative care probably doesn't have all the answers to this debate, because a lot of this debate is about choice and control. But all I can say is that palliative care could be improved in New Zealand, and I wish we were talking about that and how to improve it. A patient came in, and this isn't a reflection on poor palliative care, but I was looking after recently, and they had taken overdose. They had a form of motor neuron disease, and they had taken an overdose of medication. And they came in, and I wasn't their doctor initially, and it had mentioned in the admission notes that they wanted access to medicinal cannabis for pain. So everybody's focus, you know, because cannabis is in the referendum and everybody's interested in cannabis, so, and then this person had attempted suicide, so that was also kind of in the referendum area. So all the focus of everybody is how do we get the medicinal cannabis, so that was before the weekend. And then I met them, and nobody had actually sat down and talked to them about why had they attempted to kill themselves. And so spending an hour with them, all they talked about was their loneliness and the issues in their family that they had no one to talk about. So there's so much that we could do to improve to ease the suffering of people. And in the end, and at the moment we're just talking about this issue, which is like the tip of an iceberg, when deep down we should really be talking about the reality of facing dying, how we care for people, how we deal with suffering. Anyway, that's slightly off the topic. So there's an awful lot that could be improved, not just palliative care, and I wish we were having a conversation about that in community halls throughout the country.
Thank you. So you've been very patient.
Well, two things, Sinead. I wonder what the effect will be on, I wonder what the effect will be on doctors, because if you're of the mind, like you, Sinead, that you can care for people, and if you're going to be put aside within the hospital, you know, is the field going to become more complex for a doctor? Because if a doctor or a nurse operates from their belief and they pass on the person's view, I just feel we'll put good young, perhaps student doctors off going into this whole area of elderly care. I mean, but the other thing that has shocked me tonight, and I'm so pleased I came, I have 9 young grandchildren growing up. I hate to think that my 18-and-a-half-year-old grandchild might be able to say to their parents, "Butt out, my life, I'm checking out." When, in fact, I think medically, or the brain of a young person isn't fully formed till they're 25. And I think how much is it disempowering the parent who is in loving care. You know, you get your kids, and we've all been through it. "Oh, Mom, you don't know anything. I'm going off to whatever." And I just feel I'm quite horrified. I want to alert my children that their kids are entering into this time that society kind of doesn't back the parents. At 18, when a brain, and some 18-year-olds are very underdeveloped, and that's just, it's not a question, but that's just my feeling of that society is leaving our young people down and leaving parents down, because it's a whole area that an 18-year-old, a 20-year-old could defy a parent on. And I mean, you love them and you're expected to look after them, and yet you're suddenly saying to a perhaps defiant, maybe a slightly cannabis or druggy kid who just wants to have life on their terms. I think there's great heartbreak for families. Okay, I don't know how, there isn't an answer, That's just my the impact tonight.
I'd just like to comment briefly on that. One of the reasons I'm here or involved in this issue is because I have grandchildren and I think about their futures.
Yeah.
And I think John covered a lot of ground, didn't have time to really get into this, but just very briefly, what in my view is almost inevitable is that if you open the door to this, even quite narrowly, and some might argue it's relatively narrow, it inevitably opens wider and wider. That's happening in Canada right now. They're expanding their law after just 4 years. They're removing prognosis as a requirement for eligibility. That's huge. The Netherlands, the same thing. And the Netherlands has now reached the stage where there's a bill before the Dutch Parliament that essentially says if you're over 75 and if you're tired of life, you could access euthanasia. That is a hugely dark and dystopian future that I think they're facing. And that's the sort of thing. Now people say, oh, you're being dramatic or you're just scary. I don't think we are. Once you let the genie out of the bottle, you simply can't stop it because it moves from a sort of a compassion-based argument to a rights-based argument. Well, if that person's got access, it's not fair that I don't have access. So you widen the criteria. And so it goes on. And there's a lot of evidence to suggest that, particularly in the countries where it's not just assisted suicide, but it's euthanasia, like the Netherlands, like Canada. And so I'm fearful about the normalisation of managing death in this way and the implications of that for my grandchildren. So that's why I'm here.
And rights become duties.
Well, that too, but that's a good question. Thank you. Sir, that microphone's working, grab it. Is it died a dead? Barry, if you hold it, it miraculously works.
Hi, I'm young. I hope not to die in the next 6 months for the next 40 years. But I was wondering if you could use an advance directive to say that if I was to get into an accident where I would be dying in 6 months, then I want to have access to this. I was just wondering if you can use the advance directive in conjunction with the sort of legality.
The law as it stands rules that out.
Yeah.
Okay.
Yep. Again, that could change in future, but that is a change that would have to go right through Parliament. So the current law rules that out. Except I think that the chink in the armour already, and I've spoken about it, is the fact that in our law, and to me it's inexplicable why our MPs didn't pick up on this, because there was an SOP, but there is no requirement for a person to actually be assessed as competent at the point at which they take the final dose. So that's already a little step, unintentional maybe, but there's already a chink there. And it's one of the major flaws in the Act. One of the easy ways they could have made it a lot safer. But the simple answer to your question is absolutely no.
I just had I saw him, here we go, sir.
No?
Might be easy to stand and yeah. It's okay.
I don't have any grandchildren, obviously. I don't have a child. In here, I hear that I was struck by the 18-year-old requirement, and we are all talking about the possible danger for our young ones. And look who attended this when how many of you are 18 years old. My question is, I'm for no, but how do we educate, or what's going on, or what do you have that is being done to educate the 18 years old, because the government is encouraging them to vote. We cannot discount the vote, and if they're misinformed, they might not vote in the right way for the question here. So my question again is, what are we doing to educate them well?
Just quickly, and I'll let Peter have a shot. The question for me is about the education of all people, not just 18-year-olds. I've spoken to some 18-year-olds who are very onto this and who understand it very well. But we know, and I referred briefly to it in the presentation, most New Zealanders have no idea what this is about other than some vague idea of, well, it'd be good to have a choice at the end of life if you are in this terrible suffering. That's about as much as people know. It is more complex than that. It is quite a complex issue. And I, for one, am opposed to the idea that issues like this should be decided by referendum. I don't think that's a legitimate exercise of our democracy. I think we have a different style of democracy, and I actually think the MPs failed us on this. But that's my personal view.
Cool. Do you have a comment, Peter?
There are several organisations that are trying to get the message out on both sides of the issue, actually, and I think that's a good thing. And as long as people are informed and read and thought about the implications, we can't ask for more than that. I think my main concern is that a lot of people aren't particularly well informed, and John alluded to that. A lot of people hardly know there's a referendum, let alone the detail of what's in the Act.
I've got 2 more questions here, so I won't lose them. And one right at the back, so 4. Okay.
I just wanted to reinforce the point by John here that the amount of ignorance out there by people, and through no fault of their own actually, about some of the things John's raised. Actually, a lot of these things that John's raised were heard by the select committee process, which actually is a bastion of our constitutional lawmaking process, because that's the process by which we hear the impacts, the risks, and the benefits that a new law might create for people. But by Parliament passing this decision to the public through a referendum, it's rendered the select committee process silent. It's rendered anybody who spoke about concerns and benefits of this law to that committee, those voices are now unheard by the people about to vote on it. And that is a constitutional failing.
And it's interesting, isn't it? Was it about 38,000 submissions? 39,000. And how many of those submissions expressed concerns? Was that 80?
No, it's about 91% were opposed. And virtually any group you care to name, palliative care, doctors, nurses, healthcare workers, lawyers, people with disability, different ethnic groups, all overwhelmingly opposed. There wasn't really one strong constituency in support of this, other than the particular group that represents the issue itself.
Cool. So we've got 1, we've got 2, and we've got 3 at the back. So 1, 2. Did you have a question?
Not really. It's a little bit more of a comment. Yeah, just on the referendum situation, I guess it's like I find it interesting that like we're in a situation where we're going to vote on a referendum where there is no requirement for the person voting on it to have read the legislation. So we could all click on the box when we're reading the terms and conditions on the computer. We don't really read them. But, there's not even that in the system. So, and this is and it's also maybe confusing, but one's binding and one's non-binding. And I reckon if you even put that at the front, people wouldn't even know which was binding and non-binding. So, yeah, it's interesting that this man just commented about how it went to the select committee. And I guess this could be a question: is why didn't the select committee do a better job at helping design a better law? If this one is such a bad one.
There's a lot that could be said on that. I'm a real believer in democracy, but I have to say this particular select committee process shook my faith a little bit. And it is interesting to note, it's just a small thing, but I think it's significant. We have electorate MPs, don't we, about 80 odd, and then we have the list MPs. Yeah. The electorate MPs, a majority of them actually voted against this bill. There were more who voted against it before. It was really the list MPs that pushed it through, particularly the Greens was at first. So, and that opens up a whole lot of things that I'm not going to go into. But I find it interesting because the electorate MPs, it's a curious process, but they somehow detect the pulse of their constituents. And so the fact that a majority of them voted against this act, I think, is significant. And we hold on to a bit of hope that we might yet turn the tide in our favour in the referendum because of that.
So we're good for another 5 minutes or so? People pretty okay? Cool. So.
Okay, so if good quality palliative care is not a given right to every citizen of New Zealand, as it should be, as I believe it should be, then what choice is there in the end of life? Similarly, with the abortion law, if a young woman is pregnant and her option is to be abject poor, single mum, who is stigmatised by society, is there a choice between having the abortion or having to live a life filled with stigma and on a benefit and You know, is there another choice? Is there a balanced choice in this between palliative care and ending your life? Like, are both choices given as equal weight? And
Well, I suppose it's what John has said in the past. I mean, if there was excellence of palliative care, that everybody in the country was going to get the best internationally recognised standard of palliative care, maybe then we could talk about, you know, introducing euthanasia when that's the basis of which you should start to provide the best care that you can possibly do. So we haven't reached that at all. So, I mean, I clearly am opposed to this legislation, and I'd suggest that the people who are in favour of it kind of have hijacked the word choice. Palliative care, we feel, is all about choice. How can we care for you? What can we do for you next? What do you need next in your suffering? You know, it's an intensive form of care. We give all of ourselves, all the team members, into that. Time to provide every bit of choice that we can. So palliative care is all about choice. That's our dream for that individual, and that's our aim. And to get that for everybody in the country is probably what we should aiming for. Aiming for the stars, not for the mud, which is where I think we're looking into.
Agree.
Thank you.
I have two questions. One is the presentation tonight's obviously being recorded. Is there a way that we can access that after this evening? Because there's a lot of people I'd like to share it with. Had some very heated discussions and work this week when they knew I was coming tonight. And secondly, I'm a bit of a numbers person, so if, for instance, 50% of our voters vote yes for this referendum, and that might represent perhaps 1 million people, as opposed to those who vote no. But what I'm trying to say is, at what level does this go through? Does it have to have a minimum number of people who have voted for it? It doesn't. And it only has to beat the no's by one for it to automatically come.
Just
So
the
that's-
simple majority. Yeah, 50% plus one, either way, wins it.
Of those who vote.
I've got one more question right at the back. Is there anyone else with? We've got two, so we'll do two more questions. So and then we'll break. Yeah. So there, at the back.
Well, my question is about at least any current limitations of palliative care. So I think it's aimed particularly to you, Sinead. Okay. Can Sinead explain about this matter? My gut feeling is that euthanasia is not the right answer to any problems we may encounter. But I must give you a true case history example from my own family annals. The problem here is, as I see it from my own perspective, that my cousin's husband was a doctor, a caring doctor in Thames, New Zealand, who got cancer in the spine, which was extremely painful. The pain was increasing as he neared death. When would death be? Being a doctor, he knew pretty well much of what was happening to him, about his pain, and about what possibilities there were for alleviating it, and how it would kind of get worse as he approached death. So, knowing the reality of pain, probably if the law allowed it, he would have been a euthanasia case. He eventually got to the stage that the pain was so horrific, so painful, that he decided to refuse all food and drink, and so his life ended from that way. Now this did not involve, and nor would he, from his own principled perspective, have challenged the current law. This did not involve a negative sort of intervention by any other medical practitioner. He was not prepared as a doctor to put it to other medical professionals to assist him to end his life. Now, it's claimed by his surviving wife, my cousin, who herself is a nurse, that no palliative care would have been sufficient to have alleviated his intense pain as he neared death. Is it true or not that no palliative care would have been sufficient to have alleviated his condition without the loss of consciousness? If that's really the point of issue. My cousin's husband chose, rather than dying in an unconscious state, drugged up for the hilt to alleviate his intense pain, that he should should refuse nourishment and so end his life within about 4 days.
Okay, thank you.
Have I sort of made the situation sufficiently
You certainly have.
to comment about any current limitations of palliative care in terms of consciousness of the patient?
Well, the aim of palliative care is to relieve someone's suffering. I can't really comment because everyone's so individual, and as a doctor I care for the person in front of me, so I probably don't know what your cousin's husband treatment was, what medications he had, what radiotherapy he had, what nerve block procedures, what epidural procedures. All those are the things that we use for, in the Wellington area, for example, to help people who have that severity of pain. So I don't know what all treatment options they went through, but palliative care has advanced and continues to advance all the time. 30 years ago, there was a lot we didn't know, and we've made huge progress. And in other countries, they've made even more progress in the medications and the interventions that are possible for pain relief. So for example, if, in oncology and cancer, we're constantly making progress. Years ago, we wouldn't have been able to treat the cancers that we can. But because everyone is interested in, exploring treatments for cancer, there's research going on, there's money being poured into it. So, yet in palliative care, when we say people are still suffering, we say, oh yeah, well, let's introduce euthanasia, rather than, well, let's do more research, improve our pain relief, the ways we care for some. So what's the different attitude? Like in a neurosurgical, we're constantly, creating new ways of treating brain tumors or doing magnificent brain surgery. If we ask so I'm trying to say is, why are we thinking that we can't advance and improve the care that we can do in palliative care? Why is everybody's hands up, let's just introduce euthanasia? So, yeah, that's kind of...
That's obvious, but currently, within the last 5 years, when all this took place...
I don't know what that person's treatment options they had.
You believe yourself that there is current knowledge of how to administer medication, palliative medication, such that no case at all would be like my cousin's?
I cannot say that. I don't know exactly what treatment they had. If that person was in front of me, I would do everything and explore all the means possible to relieve their pain.
I think you're probably sensing that Sinead's probably not able to quite give you the answer that you're looking for in this forum. So there may be an opportunity for that too. I'm aware that I've completely mucked up the 8:15 finish, and never mind. I think we had 2 more quick comments. So, ma'am, yeah.
One thing that needs to be remembered, and you didn't mention it, John, about how the patient must bring up the subject with their doctor. No doctor, they absolutely have to be ineligible if they mention, oh, well, you're terminal. This is a thing, it's a person with a terminal illness. And talking about 18-year-olds who would be eligible if this passes, that if they're 18 years old and have terminal illness that likely to die with very soon, they have been through a lot. In their lives, they will have been old above their age, because this is not a terminal illness for anybody, is something that is humbling, frightening, and they will have gone through a lot already. And also all the criteria that the doctors have, so that's just one thing I think about an 18-year-old, which the thought of 18-year-olds being in this sort of situation is abhorrent to all of us, especially grandparents and things like that. But before the doctor can even think about and things like the 18-year-old, the New Zealand citizen, but an advanced state of irreversible decline of physical capability, and of course the terminal illness for 6 months, and that can't be relieved in a tolerable way. And they've got to be competent to understand that the doctor is legally bound to check all the way through. If they pass through this, to question them all the time to test their competence and their pressure, or pressure from anybody. Otherwise, they will not be eligible. If the doctor thinks even for one moment that someone's pressing, that by law, they have to stop. But the 18-year-olds would be beyond their age, even though that's a number, if they've got a terminal illness.
Would be much comfort to the parents, I think, if they had no say. That's what I would think.
I would love that the parents were there all the way through. I mean, that's how it should be.
Peter? I mean, there's a whole range of scenarios to play around what you're saying, and I understand that, you know, for one young person, they might stay their time a little bit and walk through a process. The problem is, this Act, if you imagine a scenario where an 18-year-old gets a terminal diagnosis, and I was talking to a doctor just today about this, you're shocked, you're stunned, it's come out of the blue, and as often as not, it's accompanied by depression. That's when you're most vulnerable. It's quite conceivable that someone in that situation could immediately say, I want to invoke this Act, I'm going to go and see a doctor, express the wish, and that can move as fast as John said, as 4 days. So to paint a scenario where someone's going to walk through the period of terminal illness and grow beyond their years in that may happen, but there's no guarantee that it will. It could be all over within the space of a couple of weeks from diagnosis. And that's the thing that scares me. And there's nothing in the Act to stop. There's not even a cooling off period. I mean, even a door-to-door salesperson has a 5-day cooling off period. There's nothing in, you know, that's true. If you buy something, you've got 5 days to change your mind. In this Act, there is nothing like that other than the 48 hours to issue the medication. So again, you have to explore all of the cases around the fringes as well as in the middle. And those are the things that I think John spoke to this very well. No one's saying that it won't work for some people, it will. But there are cases where I think the outcome would be a travesty, and in my opinion would represent a wrongful death for one reason or another. And so in that respect, I think this law is simply unsafe. It doesn't have sufficient safeguards, and I think we should turn it over and explore the alternative options that Sinead is really advocating around better palliative care and making progress in those much more life-giving ways of thinking about these issues. Thank you. Lucky last comment.
Or question.
Monica, that somebody may want a copy of the video, but we have to be on John's agreement with his presentation and with the quality of our videos up to it. We're very last minute with this. If you're interested in that, if you could just write down your name, who you've signed in, and if you can let us know through Eventbrite, the book, if you would like the copy of it, we'll see what we can do. Okay?
All right, thank you. So look, what we'll do is...
Is the video available on YouTube or the internet?
Look, in principle, if the quality is okay, I'm okay for it to be shared. We will put it up on our website. So, yeah, I've got no problem with that, as long as the quality is good enough. I tried to listen to something the other day that someone had taken, you couldn't hear the person. The picture was okay, but you couldn't hear them. So, yeah, subject to quality, yes. In the meantime, there are a couple of flyers for people to take. This one, which the Care Alliance has authorised, does pick out some of the key points that I spoke to tonight. So that's available at the door as you go out, and it does cover not all, but a lot of the presentation, and there is this flyer here as well.
Okay, look, many thanks. I just wanted to thank you all so much for coming tonight and for engaging so well, so I do appreciate that. So thank you. To Sinead, Peter and John, great thanks for your time and your input for this evening. So look, there is supper there. Whatever else happens, enjoy the rest of the week, and I'm sure the spring weather will come soon. Take care.